Good morning, ladies and gentlemen. Today we decided that we will hold a small webinar on dengue, essentially because all of us are going through this mini epidemic of dengue in this region. And for this webinar, we have three speakers. The first is a junior resident from Department of Medicine, Dr. Sejal. She'll be talking on the epidemiology, the virus, and the pathogenesis of the disease. This will be followed by Dr. Arihant, who is senior resident. He'll be talking on the clinical features and lab diagnosis. And finally, Dr. Navneet, who is also senior resident, will be talking on the management and vaccination. So I would request Dr. Sejal, junior resident from the department, to talk about the epidemiology, the virus, and the pathogenesis of the disease. Sejal.
Good morning, respected faculty, my seniors, and all my colleagues. Today we'll be presenting an overview on dengue, among which I will be representing the epidemiology part. Epidemiology basically comprises host, agent, and environment. So in host, there are two main and mosquito. Mosquito is mainly female Aedes aegypti and Aedes albopictus. Talking about the female mosquito, which is mainly responsible for the dengue fever, because it needs only the proteins present in our blood for its completion of life cycle, and male mosquito feeds only on the plant nectar. Female Aedes can lay 300 eggs during her lifetime and pass on the virus to next progeny through eggs. And eggs have a property that they can withstand desiccation even for 2 years. So even after they get the water or favorable condition, they can hatch the mosquito can arise from them. And altitude also remains a restriction for mosquito because they can't fly above 1000 feet above the sea level. They are anthropophilic and rest in cool, shady places and survive best between 16 to 30 degrees centigrade. Aedes become infective only when it feeds on viremic patient, that is only from a day before to the end of febrile period, that is 5 days. Talking about the agent, dengue virus belongs to the arbovirus, that is arthropod bone viruses, genus Flavivirus and family Flaviviridae. It is a single-stranded RNA and is small in size, 50 nanometer. There are 4 serotypes: dengue virus 1, dengue 2, dengue 3, and dengue 4. These 4 serotypes are genetically similar and share approximately 65% of their genomes. Still, they are different enough to elicit cross protection only for a few months after infection by any one of them. Infection with one serotype confer lifelong immunity to that virus serotype only. And among serotypes also, subtypes and genotypes are detected within each based on their phylogenetic analysis of the genomic region in the envelope gene. Recently, a discovery of fifth serotype of the dengue virus, that is dengue 5, was first detected in 2007 in Malaysia and was announced as a separate dengue 5 in 2013 October. The genetic recombination, natural selection, and genetic bottlenecks have been implicated as a factor which may lead to the emergence of new serotypes. And present spillover of the Selvatic dengue 5 suggests that adaptive barrier for the emergence of Selvatic dengue virus in human is either non-existent or too low to be of significance. And this also makes the vaccination prospectus little difficult. Talking about the pathophysiology, a mosquito takes a blood meal from a person with acute dengue. Then in the mosquito, it infects the midgut epithelium, and it takes around 8 to 10 days as an extrinsic incubation period, and then goes back to the salivary gland. And when the mosquito feeds on the human, again it can infect several humans at a time. And with intrinsic incubation period of 4 to 7 days, the febrile phase manifests. Den virus is inoculated into dermis and epidermis, and some virus is also injected directly into the bloodstream. In the skin, this delivery results in infection of macrophages, dendritic cells, and Langerhans cells, which migrate to the lymph nodes and triggers the recruitment of monocyte macrophages, then become subsequent target of den virus infection. Number and variety of cells infected with the den virus increases, and the infections can become disseminated throughout the lymphatic system with the infection of cells of mononuclear lineage, myeloid dendritic cells, and liver and spleen macrophages. Den virus can also infect liver in the form of hepatomegaly and hepatic dysfunction, resulting in apoptosis of hepatocytes. And when apoptotic den virus infected hepatocytes are engulfed by Kupffer cells, they form Councilman body, the classical histopathologic finding. This diagram represents how the dengue virus attached to the host cell and lead to the new virion formation. It attached with the help of its envelope protein to the unknown receptor. Then there is a receptor mediated endocytosis. Then pH-dependent rearrangement of envelope protein facilitates the fusion of viral and endosomal membrane to release the nucleocapsid, which disassemble to release the capped viral genomic RNA, which is then translated into a long polyprotein, which is cleaved by the non-structural 2B or NS3 viral proteases and host proteases into individual proteins. The released NS proteins are targeted to the site of replication in the endoplasmic reticulum to initiate the transcription. The precursor form of membrane proteins and the E proteins are embedded into the endoplasmic reticulum and enclose the newly formed nucleocapsid as it buds into the endoplasmic reticulum to form an immature particle. The virion is finally released from the host cell with the release of peptide. Talking about the NS1, it can be endoplasmic reticulum encode, membrane associated or secreted. Intracellular NS1 is involved in the membrane associated early viral RNA replication. Secreted NS1 activates the innate immune system and is implicated in vascular leakage. NS1 is also transported to the cell surface where it either remains associated with the cell membrane or is secreted as soluble lipid associated hexameric species. Secreted NS1 can be detected in the blood of infected patient from the first day of symptom and circulates at the level in nanogram per ml to milligram per ml during the acute phase of infections. And the blood level correlates with the peak viremia and disease severity in secondary den virus infection. Talking about the immune status, infection with any den virus result in a long-term homotypic immunity, that is immunity to the serotype to which the host is being infected, and short period of heterotypic immunity. There are two kinds of antibody in dengue virus, neutralizing and non-neutralizing. Neutralizing antibodies are a kind of blocking antibodies which circulate for a lifetime and are thought to explain the long-lasting protection against reinfection with homotypic den viruses. Epidemic with high incidence of dengue, hemorrhagic fever have been linked to the primary infection with den 1 followed by den virus 2 or den virus 3. The majority of the circulating antibodies are non-neutralizing and are directed against various antigens of the envelope protein and precursor membrane protein. Non-neutralizing antibodies enhance the entry of any den virus into Fc receptor bearing cells, and this phenomenon is called antibody dependent enhancements and make den virus unique among the human viral infections in that the pre-infection immunity to one or more virus, so-called sensitization, upgrades the disease severity, which is a paradox. As such, severe dengue and dengue hemorrhagic fever occur most often in individuals with monotypic immunity during a second heterotypic den virus infection. Third and fourth den virus infections are typically mild or asymptomatic. This diagram depicts the various factors involved in the den virus disease response: immune status, viral strain, genetic status, and age. And relative contribution of the T cell to the protection is not well understood, although there is growing evidence that both components, that is antibody and T cells, are required to prevent the infection over disease and severe diseases. Now in pathophysiology, two more important things are vascular permeability. Usually vascular permeability occurs on the first day after the onset of fever. It is more of reversible thing. There is no permanent endothelial damage. It is basically a glycocalyx dysfunction which is seen during the infection and leads to temporary alteration in characteristics of fiber matrix and endothelium. Anti-NS1 antibody act as autoantibodies that also cross-react with the non-infected endothelial cells and platelets and trigger the signaling, which leads to alteration, disturbance in permeability. This leads to a combination of hemoconcentration, pleural, pericardial effusion, orositis, and various organ involvement. The thrombocytopenia in dengue is believed due to 3-4 reasons. That is transient bone marrow suppression, increased peripheral destruction of platelets during the febrile and early convalescent phase of disease, and there is a suppression of the production of all blood cell types during the early febrile phase of den virus infection. And towards the end of febrile period, the bone marrow cells recover to the normal density and diversity. Disseminated intracellular coagulation is also considered as a cause, and peripheral sequestration of platelets. Temporal and peak production of complement split products correlates with the blood fibrinogen level and thrombocytopenia. This basically means complements are also activated both by alternative and classical pathway in the pathogenesis of dengue. The mechanism of coagulopathy in dengue are still unclear, but consistently there is increase in APTT and decrease in fibrinogen concentration. The release of heparin sulfate and chondroitin sulfate from the glycocalyx also contributes to coagulopathy. This diagram basically depicts all the pathogenic mechanism. That is, dengue virus infect the mononuclear cells, replication in Langerhans cells and splenic macrophages, which leads to endothelial cell dysfunction in the form of affecting glycocalyx. liver replication in hepatocytes and Kupffer cells, tissue macrophages, which subsequently get apoptosed, and bone marrow suppression. And all this combination leads to endothelial dysfunction and development of coagulation disorder. Thank you.
Now I'll request Dr. Aryan to present the clinical features and the lab diagnosis of dengue.
Thank you, sir. Thank you, sir. So we'll now discuss the clinical features of dengue. So dengue can range from asymptomatic infection or mild illness to severe disease. An estimated 1 in 4 dengue virus infections are symptomatic. And symptomatic dengue virus infections most commonly present as mild to moderate non-specific acute febrile illness. Infection with one of the 4 dengue viruses will induce long-lived immunity for that specific virus only. Because there are 4 dengue viruses, people can be infected with dengue virus up to 4 times. Approximately 1 in 20 patients with dengue virus disease progress to develop severe life-threatening disease called severe dengue. The second infection with dengue virus is a risk factor for severe dengue. So early clinical findings are non-specific. These do require a high index of suspicion because recognizing the early signs of shock and promptly initiating intensive supportive therapy can reduce the risk of death among patients with severe dengue to less than 0.5%. This emphasizes the requirement of suspecting the complications earlier. So the guidelines for classification of dengue. So in November 2009, WHO issued a new guideline that classifies symptomatic cases as dengue or severe dengue. So what is dengue? Dengue is defined by a combination of more than equal to 2 clinical findings in a febrile person who traveled to or lives in a dengue endemic area, which are nausea, vomiting, rash, aches, and pains. It also encompasses a positive tourniquet test, leukopenia, and warning signs like abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleeding, lethargy, restlessness, and liver enlargement. The presence of a warning sign may predict severe dengue, but it does not contribute as a criterion for defining a severe dengue. What is severe dengue? It is defined by dengue with any of the following symptoms. So we have 3 major symptoms: severe plasma leakage, severe bleeding, and severe organ impairment. Plasma leakage has to be severe, leading to shock or fluid accumulation with respiratory distress. And organ impairment is manifested, maybe manifested as acute liver injury with transaminitis, with the OTPT being more than 1000 international units per liter. There may be impaired consciousness, or there may be myocarditis or heart impairment also. Dengue begins abruptly after a typical incubation period of 5 to 7 days, and the course follows 3 phases, which are febrile, critical, and convalescent. What is febrile phase? Febrile phase typically lasts 2 to 7 days and can be biphasic. Other signs and symptoms may include severe headache, retroorbital pain, muscle, joint, and bone pain, macular or maculopapular rash, minor hemorrhagic manifestations including fatigue, ecchymosis, etc., or a positive tourniquet test result. Some patients may have injected oropharynx and facial erythema in the first 24 to 48 hours after the onset. Warning signs were developed in the later portion of this phase, that is febrile phase. Critical phase, it begins at effervescence and typically lasts 24 to 48 hours. Most patients clinically improved during this phase, but those with a substantial plasma leakage can develop severe dengue shortly as a result of marked increase in vascular permeability. Initial physiological compensatory mechanisms maintain adequate circulation, however, which narrow the pulse pressure as the diastolic blood pressure increases. So, in critical phase, so as to counteract the capillary leak, which has caused decreased intravascular volume, the diastolic blood pressure may increase as a compensatory mechanism, which may lead to a fall in the pulse pressure. Patients may also develop severe hemorrhagic manifestations in the critical phase, including hematemesis, bloody stools, menorrhagia, especially if they have been in prolonged shock. Uncommon manifestations in this phase include hepatitis, myocarditis, pancreatitis, and encephalitis. Then convalescent phase. As the plasma leakage subsides, the patient enters the convalescent phase and begins to reabsorb the extravascular intravenous fluids and pleural and abdominal infusions. The patient's well-being improves, hemodynamic status stabilizes, although he or she may manifest bradycardia, and diuresis ensues. The patient's hematocrit stabilizes. Okay. The patient's hematocrit stabilizes or may fall because of the dilutional effect of the reabsorbed fluid. The white blood cell count usually starts to rise, followed by recovery of the platelet count, and the convalescent phase rash may desquamate and may be pruritic also. Then laboratory findings. What are the laboratory findings in dengue? It may include leukopenia, thrombocytopenia, hyponatremia, elevated OTPT, that is transaminases, and normal ESR. Now, a slide regarding dengue in pregnancy. Perinatal transmission can occur, and peripartum maternal infection may increase the likelihood of symptomatic infection in newborn. Of the 41 perinatal transmission cases described in the literature, all developed thrombocytopenia and most had evidence of plasma leakage, evidenced by ascites or pleural effusions, and fever was absent in only 2 cases. Nearly 40% had a hemorrhagic manifestation, and 1 in 4 had hypotension. Perinatally infected neonates typically become ill during the first week of life only, and placental transfer of maternal IgG against dengue virus from a previous maternal infection may increase the risk for severe dengue among infants infected 6 to 12 months of age when the protective effect of these antibodies wanes. The diagnosis in dengue. So, dengue virus infection produces a broad spectrum of symptoms, many of which are non-specific. A diagnosis based only on clinical symptoms is unreliable. So, early laboratory confirmation of clinical diagnosis may be valuable because some patients do progress over a short period to severe disease when early intervention may be life-saving. So, lab diagnosis can be broadly classified into viral isolation, nucleic acid detection, viral antigen detection, detection of neutralizing antibodies, and combination of the aforementioned modalities. So, before day 5 of illness, that is during the febrile period, the dengue infections may be diagnosed by virus isolation in the cell culture, detection of viral RNA by nucleic acid amplification tests, or by detection of viral antigens by ELISA or rapid tests, like we do in emergency. After day 5, dengue viruses and antigens disappear from the blood, coincident with the appearance of specific antibodies. Antigen antigen may be detected in some patients for a few days after defervescence. So, viral isolation. Viral isolation in cell culture is usually performed only in laboratories with the necessary infrastructure and technical expertise. For viral culture, it is important to keep the blood samples cooled or frozen to preserve the viability of the virus during transport from the patient to the laboratory. The isolation and identification of dengue viruses in cell cultures is less sensitive and usually takes several days. And molecular methods based on RT-PCR have been combined with the cell culture method to improve the sensitivity and reduce the time. The isolation of virus from clinical samples can be conveniently carried out with cultured mosquito cells or mammalian cells. And at present, viral isolation with a C636 cell line with acute phase serum or plasma from the patients is the method of choice for routine dengue virus isolation. So, what is nucleic acid detection? That is a molecular method. It may identify dengue viral RNA within 24 to 48 hours. However, these tests require expensive equipment and reagents. In order to avoid contamination, these tests must observe quality control procedures and must be performed by experienced technicians. These assays use the dengue virus code to pre-membrane gene regions as a target sequence for dengue virus detection. And nucleic acid sequence based assay and isothermal amplification assay can detect viral RNA on clinical specimens also. The real-time PCR or the RT-PCR assay has many advantages over the conventional PCR, including rapidity, the ability to provide quantitative measurements, a lower contamination rate, a higher sensitivity, a higher specificity, and easy standardization. It has replaced the conventional PCRs. Then viral antigen detection. This can be done by ELISA and dot blot assays directed against EM and NS1 antigens. Can be detected in the acute phase sera of patients with both primary and secondary infections up to 9 days after the onset of illness and is less sensitive. Now, another modality is detection of neutralizing antibodies. Antibody response to infection differs according to the immune status of the host. So, when dengue virus infections occurs in persons who have not previously been infected with the flavivirus or have not been previously immunized with the flavivirus vaccine, for example, for the yellow virus, Japanese encephalitis, or tick-borne encephalitis, the patients develop a primary antibody response characterized by a slow increase of specific antibodies. IgM antibodies are the first immunoglobulin isotype to appear. These antibodies are detectable in 50% of patients by day 3 to 5 after onset of illness, increasing to 80% by day 5 and 99% by day 10. IgM levels peak about 2 weeks after the onset of symptoms and then decline generally to undetectable levels over 2 to 3 months. Anti-dengue serum IgG is generally detectable at low titers at the end of the first week of illness, increasing slowly thereafter, with serum IgG still detectable after several months and probably even for life. In secondary infections, antibody titers rapidly and react broadly against many flaviviruses. The dominant immunoglobulin isotype is the IgG, which is detectable at high levels even in the acute phase and persists for periods lasting from 10 months to life. Early convalescent stage IgM levels are significantly lower in secondary infections than in primary ones and may be undetectable in some cases depending upon the test used. To distinguish primary and secondary dengue infections, IgM by IgG antibody ratios are now more commonly used than the hemagglutinin inhibition test. So this is the summary of the operating characteristics and comparative cost of dengue diagnostic methods. So we have viral isolation and serotype identification, which confirms the diagnosis of dengue and usually takes around 1 to 2 weeks from the onset of illness to confirm the diagnosis. Specimen is usually whole blood, serum, or tissues, and time of collection is 1 to 5 days only. Then we have nucleic acid detection, we have antigen detections, we have IgM ELISA, we have IgM rapid tests, and we have IgG paired serum. So, a point to note from this is that dengue infection can be confirmed only by a nucleic acid detection, viral isolation, or by a paired sera. That is, if we are able to demonstrate a 4-fold increase in titer of IgG antibodies in paired sera, then we can confirm it. Otherwise, all other diagnostic modalities only give a probable diagnosis, including the antigen tests and antibody tests. So, what is the interpretation of dengue diagnostic tests? So, patient is told is considered to be confirmed dengue if he is PCR positive, he is viral culture positive, IgM seroconversion in paired sera is demonstrated, and IgG seroconversion in paired sera or fourfold IgG titer increase in paired sera is demonstrated. But it is considered highly suggestive if only one of the following is present. That is, a single serum sample showing IgM or a single serum sample showing IgG is only a highly suggestive of dengue, if not confirmed dengue. Thank you.
Now I would request Dr. Navneet to give us an overview of management and vaccination. Dr. Navneet.
Good morning, all. I will be dealing with the management of dengue fever. So, as we know that dengue is a self-limiting illness, the management of dengue depends on the severity of illness. Fever without danger signs and complications can be managed symptomatically, while fever with warning signs require close monitoring to see for the disease progression. In the clinical management of dengue hemorrhagic fever, significant bleed or organ dysfunction, aggressive management is required to reduce mortality and morbidity. IV antibiotics, intravenous immunoglobulins, or steroids have no role in the management of dengue fever. The dengue fever without any warning signs can be treated by bed rest, cold tepid sponging, and the target temperature which is to be kept is below 38.5 degrees Celsius. Antipyretics, which is paracetamol, which is the best used antipyretic, can be used in 500 milligram per dose and can be given 6 hours apart. However, the NSAIDs and aspirin is to be avoided. Oral fluids and electrolyte therapy by WHO ORS can be given. However, in the cases of persistent vomiting or if the patient is refusing to feed, intravenous fluids needs to be initiated. 24 to 48 hours monitoring after the patient is afebrile is required to see for the complications. In dengue hemorrhagic fever grade 1 and grade 2, the patient should be hospitalized and should be observed for signs of shock. The critical phase of dengue starts from the transition from febrile to afebrile phase of illness. So this is the most important time in which observation is required. Hemoconcentration indicates plasma leak and loss of volume. So for that, fluid management is to be initiated. So if the patient with dengue hemorrhagic fever has hemorrhagic tendencies, thrombocytopenia or hemoconcentration in the form of rise in hematocrit for more than equal to 20, IV fluid therapy with crystalloids is to be initiated at the rate of 6 ml per kg per hour for the first 1 to 2 hours. After giving the fluid therapy, the patient should be reassessed and hematocrit should be checked. If there is clinical improvement in the patient in the form of fall in hematocrit, pulse rate, blood pressure, or increase in urine output, then the IV fluid therapy can be tapered from 6 to 3, 3 to 1.5 over a period of 2 to 4 hours respectively, and the IV fluids can be discontinued in 24 to 48 hours. However, if after reassessment there is no improvement in the form of pulse rate, blood pressure, or urine output, hematocrit is checked again, and if the hematocrit is still on a rising trend, the fluid initiated should be increased to 10 ml per kg per hour over 2 hours, and then the patient should be reassessed again for the same parameters. If the hematocrit is falling and the patient is not improving, we should suspect internal hemorrhage and blood transfusion with whole blood at 10 ml per kg or packed RBCs with 5 ml per kg should be initiated. After this, the patient is reassessed, and if the patient is improving clinically and the hematocrit is subsequently improving, the fluid therapy can be initiated, which can be tapered over 24 to 48 hours. In dengue hemorrhagic fever grade 3 and grade 4, we should check hematocrit, platelet count, vital signs immediately after hospitalization. Intravenous fluid therapy should be started immediately after hospitalization, and we should observe for signs of shock. If persistent fall in hematocrit is present, whole blood transfusion at 10 to 20 ml per kg per dose is initiated. If the shock is persistent even after initial fluid replacement, resuscitation with plasma or plasma expanders is to be started. Small volume of whole blood at 10 ml per kg should be initiated for persistent shock. Oxygen supplementation for all patients in shock is important. So if the patient presents to hospital with compensated shocks, with a pulse pressure of more than equal to 20 mmHg and systolic blood pressure of more than 90, but hematocrit is rising for more than 20%, IV fluid therapy with crystalloids at 10 to 20 ml per kg per hour should be started for the first hour, and then the patient should be assessed for improvement in volume status or hematocrit. If the patient is improving in these parameters, the fluid can be tapered down accordingly, and fluid should be given for initially at 10, then 6, then 3, then 1.5 ml per kg per hour for 2 to 3 hours, and can be tapered discontinued around 24 to 48 hours. However, if after fluid initiation the patient is not improving in the volume status, we should go for the hematocrit check again, and if the hematocrit is rising, that is more than 40%, IV fluid, colloids or crystalloids should be repeated again, and the patient should be reassessed. If the hematocrit at the same time is falling, we should suspect internal bleed and go for blood transfusion as per the protocols told in the previous chart. If there is refractory hypotension still after these things, we should check for acidosis, bleeding, electrolytes and RBS, and should correct them accordingly. Still persistent hypertension, we should go ahead with inotropic support, and after maintenance of the MAP, which is more than 65, we can give maintenance fluid according to the Holiday-Segar formula. Coming to profound shock, in which signs of shock, hypertension of systolic blood pressure less than 90 and hematocrit rise is present, all patients should be started on oxygen supplementation to increase the perfusion. Then the patient should be started on IV bolus of fluid versus the 1 hour of fluid. In this, we need to give a IV bolus over 15 to 30 minutes, and the fluid should be given at 10 to 20 ml per kg per hour. If after this there is improvement in hematocrit, maintenance fluid can be given, and then it can be discontinued over a period of 28 to 48 hours. If there is no improvement in volume status, the patient should be given a bolus of fluid of 10 to 20 ml per kg again, and then again hematocrit is checked. If the hematocrit is rising, maintenance fluid at 10 to 20 ml per kg is to be started for 1 hour, and then the patient should be reassessed. In cases of refractory hypotension, inotropic support should be started. However, if the patient is unstable and the hematocrit is on a falling trend, internal bleeding should be suspected and blood transfusion should be initiated. Now, what is Holiday-Segar formula? So, according to this formula, it gives the total amount of fluid required for a given person over a period of 24 hours according to his body weight. So, for the first 10 kgs, 100 ml per kg fluid is to be initiated. For the next 10 kgs, 50 ml per kg body fluid is to be initiated, and every kg rise in body weight after 20 kg, 20 ml per kg body weight is 20 ml per kg IV fluid is to be initiated. The addition of all the three fluid requirement gives the total amount of requirement of fluid which needs to be initiated as a maintenance fluid in a particular case. So what is the role of hematocrit in a patient of dengue fever? Rising hematocrit with unstable vitals signify active plasma leak. However, rising hematocrit with stable vitals and adequate urine volume signifies improvement in the case. Falling hematocrit plus unstable patient signifies hemorrhage, for which we need to go for blood transfusion. However, in the case of falling hematocrit with stable vitals and adequate urine output, IV fluid therapy needs to be stopped and oral fluids needs to be initiated. Coming to the choice of intravenous fluids. So, there is no clear-cut advantage of colloids over crystalloids. However, colloids may be preferred choice if blood pressure has to be restored quickly. Colloids restore the cardiac index and reduces hematocrit faster than crystalloids in intractable shock and where the pulse pressure is less than 10 millimeter of mercury. The recommended IV fluids according to the Indian guidelines is the normal saline, the ringer lactate, or 5% dextrose solution. So how do we manage severe bleeding in dengue fever? Urgent blood transfusion is life-saving. If blood is not available, plasma expanders or intravenous fluids can be initiated. Thrombocytopenia with active bleed calls for blood transfusion, which is followed by platelet transfusion if required. If there is massive hemorrhage, we need to check for coagulopathy and we should correct it accordingly. So what are the indications for platelet transfusion? Prophylactic transfusions do not improve outcome. However, there are some cases in which if the platelet count is less than 50,000, we need to transfuse platelets, and those are severe bleeding, which signifies HB drop of 3 gram per deciliter or refractory hypotension or any invasive procedure like endotracheal intubation, venous line insertion, or an arterial line insertion calls for platelet transfusion and maintenance of platelet to around 50,000. If the platelet count is less than 20,000 per cubic millimeter in unstable patient or patients with associated risk factors like accelerated hypertension, patient on coagulation therapy, recent stroke, or any surgery, then the patient should have undergone platelet transfusion. Platelet transfusion is also given in patients with platelets of less than 5,000 with minor bleeding. Coming to dengue fever and dengue hemorrhagic fever with comorbid illness. Dengue-related viral hepatitis should be given a hepatic failure regime with appropriate fluid and blood transfusion for the treatment. Dengue myocarditis may cause pulmonary edema due to improper fluid management. So, accurate fluid management according to the protocol is very important. We should also assess for cardiac ischemias and electrolyte disturbances and correct them accordingly in cases of dengue myocarditis. In dengue fever with diabetes, insulin therapy is required for better glycemic control, as diabetes is a risk factor which leads to dengue hemorrhagic fever or dengue shock syndrome. Dengue fever with renal involvement is reversible if the shock is corrected over a short span of time. Urine output monitoring and monitor of fluid intake to avoid fluid overload is very important in these cases. So, what are the criteria for admission? Significant bleeding manifestations, signs of hypertension, persistent high grade fever, rapid fall of platelets, sudden drop in temperature, or any evidence of organ involvement calls for hospital admission, monitoring, and supportive treatment. How do we discharge the patient after we have treated the dengue patient? So, if the patient has no fever for 24 hours plus normal blood pressure and adequate urine output with no respiratory distress, and the platelet count is more than 50,000 per cubic millimeter, the patient is fit for discharge from the hospital. Coming to dengue vaccines. So, dengue virus dengue serotypes cross react with each other. Infection with a particular serotype confers lifelong immunity to that particular serotype. However, cross protection to other serotype is only about 2 years and wane over time. So, a second heterotrophic dengue infection will be more serious than the first infection and may lead to severe dengue hemorrhagic fever or shock syndrome initially. So, what happens is that the non-neutralizing antibodies from the complex forms complexes with dengue. They facilitate virus infection to phagocytes via the Fc receptors. This enhanced infection will lead to dengue hemorrhagic fever and dengue shock syndrome, and this phenomena is termed as antibody dependent enhancement. This antibody dependent enhancement is also a very big problem in giving dengue virus vaccine, which we will be discussing later, to the patients who are seronegative. So, dengue virus vaccines are of 5 types, which are under investigations and and they are the live attenuated vaccines, the inactive vaccines, the recombinant subunit vaccine, the viral vector vaccine, the DNA vaccines. So, all these vaccines increase immune response by acting against the E protein and the NS1 protein present on the dengue structure. So, the tetravalent live attenuated vaccines, which are in human clinical trial, is shown in this figure. Out of this, the Sanofi vaccine, that is the CYD TDV vaccine, is licensed recently by the WHO, and the WHO has given its position also on it, which we will be discussing in the subsequent slides. The tetravalent inactivated or subunit vaccines are shown in this diagram, and these are however under trial in various phases. So the only licensed vaccine is the live chimeric vaccine, which is also known as dengue vaxia, which is licensed in 20 countries in Asia and Latin America. So the dengue viral vaccines, which are under various phases of development, can be shown in this figure, out of which the phase 3 trial is only completed by the CYD TDV vaccine. So the Sanofi or the dengue vaxia is licensed in December 2015. It is approved in 20 countries in Asia, Latin America, and Australia. It is a live attenuated tetravalent chimeric vaccine in which the perimembrane and the envelope protein from the wild type dengue virus are substituted into the yellow fever 17D vaccine backbone. It is a 3-dose schedule 6 months apart, which is 0, 6, and 12 months scheduling. So the dengue vaxia has high seroconversion and a high antibody titers in previously infected individuals. However, it is ineffective against the dengue2 strain. It is approved in individuals above the age of 9 years old, and the immunity lasts up to 4 years. It is only administered to dengue seropositive individuals. Vaccine in seronegative individuals increases the risk of dengue infection. So, what is the WHO's position on the dengue vaccine? Vaccination should be considered in areas with a seroprevalence of more than 50 and should not be considered in seroprevalence of less than 50%. More than 70% it is indicated. So overall population level benefit is favorable for the vaccine, and the vaccine efficacy in seropositive individuals is 76% and in seronegative individuals is as low as 38.8%. The seronegative individuals should not be vaccinated. The CYD TDV vaccine has potential public health role. A pre-vaccination screening strategy is to be considered, as the patients who have previously acquired dengue infection are to be given this vaccine only. However, there is no data available on the booster doses yet. Thank you.
Thank you. Now, can we have the screen, please? Now, what we have seen is an overview of dengue, and before we make some comments, let us see now what are the important points which have been made and a few queries. The first query which naturally comes up is that many patients which we see where fever is positive, but the platelets are also low, but the test is negative. So it's a very common query. Are we dealing with dengue or a dengue-like disease? In other words, what are the sensitivity and the specificity of NS1 and IgM? And is it possible that both the tests are negative and still the patient be dengue? So maybe Dr. Aryant, you can take up this point, because I think 2 or 3 people have asked this question.
Thank you, sir. So the sensitivity of NS1 antigen is around 70 to 100%, roughly around 65 to 70% on an average in the first 5 days of illness. And specificity is usually around 94 to 96%. And the specificity is more better. It is better. That is around 94 to 96% specificity, but the sensitivity is only around 70%, increasing maximum to 100% in some studies.
This is also true that is it kit based, because there are there are multiple kits which are available in the market. That one kit is negative and other kit may be positive. Because normally, many times which we see that the reports which are there from negative from outside are positive here, or the tests which are positive outside are negative inside. So do we need to repeat the test once it is positive, or you take it as dengue?
So I think we need to look about the clinical status of the patient. If we are suspecting dengue clinically, the patient has all the features, like he has a capillary leak features. Imaging is suggestive of capillary leak in the form of acalculate cholecystitis and fluidic emulations like ascites effusions. So I think we may repeat the test for better diagnosis in that case.
All right. Okay. The next question which comes up is from the epidemiological perspective. Somebody has written about the fifth strain. Has it been described from India, or?
In India, it has not been indicated that dengue virus is present in India, not been isolated.
And can you tell us that is it only for the academic reasons that we need to find the genotypes, or does it have any bearing on the clinical manifestations? Because it is said now that DEN2 is possibly circulating, but I'm not too sure actually the type of serotype which is circulating in the community in Chandigarh or around, or
So
if anybody is aware.
DEN2 and DEN4 is the particular serotypes which we are isolating in CD ward. So had a word with them yesterday. So DEN2 and DEN4 are the serotypes currently circulating in Chandigarh.
And DEN2 is supposed to be a little more serious and a little more sinister because the manifestations. I don't know the reasons why it
followed by
happens.
dengue.
All right, and the next question, which is extremely important, is like everybody gets fever. Can they stay at home, or do they need a test on day 1 or day 2? What exactly would be the practical implications? Because the hospitals are crowded, the nursing homes are crowded, there are no beds, you are treating patients in corridors, on trolleys and so on. So what would be your suggestion actually for a layman, or for that matter a general practitioner? Maybe Navneet, you can take up this.
So actually, according to what the guideline says, is that if dengue has no warning signs, and the warning signs are well explained in dengue, which we have also included in the presentation, if there are no warning signs, and generally the fever subsides around 3 to 5 days, so there is no requirement for hospital admission. The panic which is created by high grade fever possibly is the reason why patients rush to hospital. But if we see them like practically, they do not require hospital admission unless and until they have warning signs of dengue fever.
Yeah, and I would also add that is the risk stratification of a given individual. Please remember that the treatment in medicine is always individualized. Guidelines are guidelines. Say a person who is taking aspirin, person who is taking NSAIDs, he had, as you said, past history of coronary artery disease, stroke, he's got a bad diabetes. Possibly you have to risk stratify, and a high risk patient should be given priority.
Sir, in those patients, in those patients, what we do is we need to check the initial investigations, and there is a particular cutoff of platelet counts which needs to be maintained. Below that count, the patient comes into the category of hospital admission and should be admitted in those patients who are high risk individuals. Otherwise, a normal individual with no comorbidity do not require admission in these particular cases.
And how frequently the platelet count should be done? Should it be done every day, alternate day, or twice a day, or is it again individualized, or there are no guidelines, what would you recommend?
Sir, the national guideline give a line of doing a platelet count of 24 hours, but they have not like specifically emphasized.
What is the practical? Let us be practical about it, or you just monitor them clinically. If person is doing fine, is there a need of doing a platelet count, or because you said that you will not give platelets, even at 5,000, you said, although one may be little, scared at that level.
Sir,
Sir, if
Yes.
the patient has borderline blood counts, like if the patient has count between 10 to 12 or 20,000, then we may need repeating it daily for around few days till the time the patient is admitted to look for the trends. Particularly if he has warning signs also, because that may help us in infusing him platelets also if the need arises.
All right, and one very important point I think which we have not covered is about dengue and COVID, because the initial manifestations are going to be the same. So, a person who comes with fever, little bit of pains here and there, would you wait or test for COVID and dengue both, or one? And what exactly would be the course of dengue patient? Suppose he is found to be COVID positive.
Sir, if the dengue patient is found to be COVID positive, then on the dengue part, only supportive treatment is required. But we need to assess for the COVID-19 infection severity also in that part. If the COVID-19 is not severe, that is not less than 94% saturation, then both the treatments can be supportive. However, particular protocols are followed when according to the severity of COVID versus dengue fever, and we need to treat accordingly. We need to treat the patient accordingly.
And would you just like to mention about atypical manifestations of dengue? Because is it always that the person was present with fever and petechiae, or could there be, some atypical manifestations like encephalitis and so on?
Sir, definitely, sir, many atypical manifestations do occur in emergency. Like many people nowadays are presenting with encephalitis. Myocarditis also is reported in few cases.
What about diarrhea? I thought that diarrhea this time is a little more frequent, or because many patients come with acute gastroenteritis, which anyway is going to be common in Diwali times. People would be eating. Is it acute gastroenteritis or manifestations of dengue?
So not frequent, sir. Not very frequent in emergency, sir. Usually, patient present with fever and generalized body aches and headache and pain abdomen was the warning sign, and then on evaluation are found to have positivity cirrhosis.
Yeah, Dr. Navni Sharma has written about the colloids. Would you talk about dextran in dengue hemorrhagic? Because dextran normally is not given because naturally it can produce platelet dysfunction. But are there any studies of dextran versus crystalloids?
Sir, there are various studies, and there is no superiority of dextran. And as Navneet sir has pointed, it is right that dextran is not used in not used generally in dengue.
Yeah, but I think that there was a study where in the sense there were no side effects but no benefits. So
No
why
benefits.
why unnecessary use a more expensive stuff? Now, very important point. Although let us be practical about it, is about the fluid management. Normally we say 6 ml per kg, hike up to 10 ml per kg. But is it not that the vascular permeability increases? That if you increase more fluids, it will get accumulated in the lungs, more respiratory distress, theoretical and occur. So, what is the practical experience? Aryanth, you have been working in emergency and after seeing hundreds of patients. What is your experience? Is it always a 6 ml and 10 ml, or you go clinically, or?
So usually we don't go like 6 ml or 10 ml. Usually in emergency, it's usually clinically only with the patient. We try to give fluids throughout the 24 hours in case the patient is not able to take orally. In case he's able to take orally, then we don't stress too much on fluid.
Sure.
With the patient, we encourage him to take fluid by himself only. we don't follow that specific algorithm like we go as per body weight in emergency. If the patient has significant clinical fluid accumulation like ascites that is worsening, then we might try albumin or colloids in that case for build up of his
Yeah,
endoscopy.
exactly. And what about the IVC diameter measurement? Again, because of increased permeability, there is always a confusion in dengue.
Sir, measuring the urine output and the blood pressure, I think, is more important as IVC in the third spacing when capillary leak sets in the critical phase. Then IVC may be collapsed in cases where adequate resuscitation is given also. However, before the critical phase, we can go by the IVC when there is no capillary leak set in. We can go by IVC, but once
Yeah.
capillary leak is there, giving fluids with IVC may or may not be useful. Sir.
Yes, Dr. Suchitra says that serovas differ in neurotropicity, one of the worst prognosis factors, so it's important. All right, Dr. Puri was asking, is dengue protective for COVID complications? I don't think,
No
yes.
established rule.
Yes, exactly. Dr. Amritpal says any serositis like micropleural effusion cause shortness of breath should be considered for admission. Yes,
Polyserositis
sure.
is an indication for admission.
All right, and now one point which we have missed totally. How do we prevent dengue? You know, what are the steps you should be taking as a doctor or as a layman?
Sir, there are non-pharmacological methods and pharmacological methods. Sir, we can use insecticide. We can wear full clothes in the dengue season, as the National Vector-Borne Disease Control Program are repeatedly telling.
And very
us.
interesting is Dr.
Radios
Navneet
also.
is rolling up his sleeves so that the mosquito can bite his arms. So there is a difference between what we say and what we practice. So you should be wearing full sleeves. All right, that's one. Second, anything else we can do?
So, insecticide-treated mosquito nets are available. We can use them.
Don't they smell? Will the
They
person be
do.
able to sleep? Let us be very frank about it. Or
So
are there good
usually-
fragrance?
Sir,
The mosquito usually bites during daytime. So
the day.
Mosquito repellents we can use.
We can
Repellents
use
can
the
be
mosquito
used.
repellents on that time, sir.
So the more important thing is the personal hygiene and possibly the garbage removal and the water, which is not there.
Stagnation.
So the first thing is that please go and check your coolers, go and check your pots, because these are the, I believe, more important things. And don't go outdoors until illness is absolutely essential, because it will prevent not only dengue but possibly COVID as well. But is the vector found only outdoors? I thought that it is both outdoors and indoors.
both
Indoor.
outdoors.
Okay, all right. Any other point which you would like to add or something? Because I wrote many of things. Now somebody said about Vidal test. Vidal test has got a cross reactivity with the dengue detection. Is it true that IgM reacts with the?
Sir, no.
No, there is no proof. You are not too sure. All right. Okay. And can you just repeat about the platelets, because that's where there is always a confusion. Is it the falling trend? Is it 20,000, 10,000, 5,000? You want, or you wait for the bleeding?
So, actually, what it is minor bleeding with 5,000 platelet count. No prophylactic use of platelet transfusion is there. There are
Let
many
us
articles.
but that is the theory. Now let us ask Dr. Aryan, what do you do in emergency? Patient has got a platelet count. I'll just give you. Yesterday, patient was 12,000. Would you transfuse? Would you not transfuse? And from PGI, or for that matter, the so-called VIP syndrome.
So sometimes to expedite the discharge of patient in view of heavy rush, if the patient has bottles at the count around 10 to 12, we do transfuse.
Yeah, Dr. MD asks, is itching a sign of recovery?
Yes, in convalescent phase, the patients may have pruritus. So that is a feature in convalescent phase. Patient has the features.
Yeah, I just wanted to ask, this biphasic thing. Dengue typically has got a biphasic. This is what has been taught, from our MBBS days.
Yes.
So, and you said that after 24 hours, the person becomes afebrile, the person can be discharged.
24 hours afebrile plus all the other conditions of normal blood pressure. And
In that situation, is it possible that we may be missing one of a very small percentage of patients who would have a biphasic illness?
Sir, initially the biphasic illness after 3 days will set in. Either after 3 days, because 3 to 5 days is the natural history in which the fever would subsidize. So, sir, we are observing them for 24 to 48 hours according to the guidelines we have to observe. Sir, if we are doing that and then we are discharging, I don't think we will be missing the complications. Neither we would be missing the second spike of fever, because it occurs between that period of time only.
So the moral of the story is that we should not be panicking. Yes, it's important to monitor the patient as a whole, just not the platelets, and one should not be just, stick to the term of platelets because more important possibly is the capillary leak, blood pressure, urine output, capillary filling time, and the general status of the patient, and the patient has to be seen as a whole. Would you like to add something? When can we expect dengue vaccine in India? Any comments on that, or is it available, or is it going to be available soon, or any ideas on that?
Sir, it is licensed in Asia though, but I couldn't find anything about India and what the studies are or about that.
All right. Anybody from the audience would like to just ask something, or I believe that we have covered all the points, or somebody Dr. Bhalla's points, serological can cross react. Pankaj, can you show? Are there more questions or any more comments? I think Dr. Sel has written, how common hyperkalemia and dengue without AKI?
Sir, actually, this is a common thing nowadays. I think, although I don't know what this has been reported, but nowadays in emergency, we are seeing many patients having hyperkalemia.
Is it because of hemolysis or something, DIC or something of that sort?
Sir, usually the patient don't have other features of DIC like any coagulopathy or any bleeding manifestations, but it was reported, it was seen in some cases.
Yeah, because what I have seen practically is lots of patients are having bradycardia. Dengue is a very known cause of relative bradycardia, but we have seen patients having a heart rate of between 50 to 60, their echoes are normal. So I don't know whether it produces sinus node dysfunction or what. Dr. Suchitra says papaya. Oh yeah, the three things: the papaya leaves, the kiwi, and the goat milk. Bakri ka doodh. The three things. Just comment on that.
There was this trial done, the PLEAD trial in around 2013. It was an RCT, single centric RCT done in India, but it did not show any benefit of papaya leaf extract. Though there are some reports that papaya leaf extract may be useful, but in the level of evidence is very, very low in that. And
kiwi and the goat milk.
so goat milk, I feel, would lead to brucellosis than treating dengue. Sir.
Rather, sir, it exacerbates thrombocytopenia because it leads to folic acid deficiency, and rather it proves to be contrary.
But goat milk, that must be over a period of months. You can't have a folic acid deficiency by drinking about 500 ml of goat milk. Okay, well, I just wanted to bring my, these type of things are always there once there is no definite treatment or no antiviral treatment. So it means that there is no evidence to suggest that any of them would work. So we would not recommend. This is a very common thing. And now I heard that there are capsules which are available of papaya leaves and kiwi which are being sold in the market. Dr. Divakar has related capillary leak causes ascites. How will you differentiate a CLD with ascites in a dengue fever? So it's complicating dengue with ascites. CLD would have its own features, it, yeah. Co-infection, DEXA. Would DEXA, if given, worsen COVID? Any idea on that?
So usually a viral infection usually is worsened by steroid therapy.
But that is more of a theoretical question. I believe that if something has to be used, it is always a risk and benefit. If somebody is using DEXA in COVID, possibly it's somebody is having hypoxia or a latent hypoxia. So there the benefits would be more than the risk nobody can judge. What about HLH in dengue? Lots of patients of pancytopenia now are documented to have HLH, which is self-limiting.
So generally it is a self-limiting thing because it is a secondary HLH. So nothing is to be done until it is persistent, and in those cases HLH needs to be treated. But however, we till now have not seen a patient which needs to be treated specifically for HLH in dengue fever. It's subsidized on its own as the the disease, the effervescence of the disease is present.
So I think with this we come to the end of discussion. Thank you everybody, and if there is any other comments, our speakers are always there, and I thank each one of them personally because I know that all of them are working very hard. Dr. Aryan is coming back after the night duty, so he spent the whole day and the night working for dengue. Similarly, Dr. Sejal, actually she mailed me at 3 o'clock in the morning, and Dr. Navneet, early in the morning at 5 o'clock, he asked me about a few things which we have to do. So I thank each one of them personally. And I believe that as a joint team, we can fight this disease, and it's going to be there for next 2 to 3 weeks. And I believe by that time the dengue would subside. So have a happy Diwali and keep safe. Thanks. Thank you.